You're listening to Be Health Connected, a podcast by the Gateway Business Health Coalition. Your host for today's episode is Laurel Pickering, BHC President and CEO.
Hi, I'm Laurel Pickering, President and CEO of the BHC, and welcome back to the BHC's Be Health Connected podcast. Today, we have not just one expert, but two, and there's a little bit of a history here, and I'm particularly excited about this conversation. We have Wendy Smith and Patty Wall, who used to be colleagues at Aon together, which makes today especially fun because now they're at competing consulting firms, Mercer and Aon. We like to think of this as less of a rivalry and more of a reunion with just a little bit of competitive spirit mixed in. Both Wendy and Patty are leading voices in helping employers rethink healthcare and delivery system transformation, and we're excited to bring their perspectives together in one conversation. Wendy is currently serving as a partner at Mercer Health and Benefits Practice, advising employers on strategic plan design, cost containment, and emerging healthcare delivery innovations for the Central Region, which is where we are. And Patty is Senior Vice President of Health Transformation at Aon, doing the same things for employers that Wendy is doing, but serving in a national capacity. But she lives in St. Louis and actually worked for BHC for a couple of years, as well as BJC, one of our major health systems. So welcome, Patty and Wendy. It's so great to have you joining us today.
Thanks, Laurel.
Great to be here.
So to kick us off, let's start at the top with what's on every employer's mind, always healthcare costs. So what trends are you both seeing right now in employer healthcare spending, and what's driving those increases today?
Sure, I'm happy to jump in. There's just a lot of common themes. High cost claimants are continuing to erode a bigger percentage of the budget, and every single employer, typical things that of every employer, such as cancer, MSK, GI, cardiac, gene and cell therapy, certainly the GLP-1 conversation that I'm sure we'll get into a little bit further. So those are some common themes that I'm seeing in terms of what's on everybody's mind. This cost trend, we're experiencing, depending on which actuary you believe, 7.5 to 9.5 for 2026, another 9%-ish for 2027 that's on the horizon. So I think the message that I always talk about is, you think last year was maybe bad. Unfortunately, we're not through with that runway. The bad kind of continues. And so we really do have to make some moves. We can no longer wait. And certainly some employers are doing that, and certain employers are still a little bit on the bench.
We're seeing the same thing. We're seeing at Aon a 9.5% trend. And healthcare costs, as we look at it, are driven by three things. That includes the price, utilization, and then the mix of care. And really none of those come with an easy button. Price, we're seeing, continues to be the biggest component of trend, but its proportion to the total increase has actually decreased, while utilization and mix has increased. And so ultimately, we're seeing employers trying to focus on getting employees to the most cost-effective care while removing the friction from the member experience. And so that's where we're seeing a rise in things like alternative health plans, on-site, near-site clinics, and then pairing some coverage decisions like GLP-1s as part of that. And then pharmacy, of course, continues to be a big lever with growing movement towards the transparent PBM models and tighter specialty management. I know, Laurel, that's something that your organization has done more on as well, on pharmacy.
Yes. Yeah, with our PBM coalition. Given both of you either have it in your title or have worked closely on delivery system transformation, how much of what we're seeing on cost is really a function of the underlying delivery system? Patty, you mentioned prices, which clearly goes right to what we're buying from healthcare systems. And where do employers actually have leverage to change that versus just managing around it? And again, Patty, you started talking about some solutions related to alternative health plans and utilization, but maybe diving in a little bit on what employers can do to change what they're buying from the delivery system.
And so one of the things we're seeing that from a care delivery standpoint is we're seeing a lot of employers double down on the notion of steering to care, more effective, high quality, more efficient care with providers. And really, we're seeing it in several different flavors. So it could be centers of excellence, which I know we have in St. Louis with several of the health systems, as well as some carve out vendors like the Carum, Lantern, Transcarence of the world. It could also be in the thought process of vendors like a Garner or an Embold or a GAM, the provider steerage that lays on top of the existing carrier. Advanced primary care models are also in St. Louis, and then alternative health plans. So really there's 4 different types of models we see is the notion of steerage to high quality. Aon just released our latest health survey, our 2026 health survey, and we found that 36% of our employer respondents said that they already have implemented a plan design that steers to high quality providers. And then another 30% are looking to implement in the next 1 to 2 years. So I think it just reinforces that whole notions of stop paying for less and steering to care that delivers.
Totally agree with that. I'm seeing a lot of the similar things in terms of the move to cost quality layovers, like you mentioned, Garner, Embold, GAM. Certainly, we know that from a delivery perspective, the cost is going up a bit, and there's a lot of contentious negotiations that are out there between the delivery systems and the carriers. And I think that many of those are going to be longer in term instead of shorter in term, just because both sides are pretty rooted in their fundamental belief that certainly for the delivery system that they deserve more, and trying to prove that out from a data perspective in the negotiations, and the carriers are saying no, we need to stay put. And so there's this battle that will go on contractually. We're seeing some of that play out with Mount Sinai, Memorial Hermann, and HCSE were at termination, and they just came back together this weekend. But yes, inside the employers' minds is cost and quality as a forefront, and we have to understand how we get that to them, whether that is through the carrier model, and the carriers are certainly trying to evolve and continue to evolve in that space. And then there's the third parties.
Yeah, it's interesting that I had in our market in St. Louis, we've had a lot of examples of these tough negotiations between health systems and health plans. I had one of our major health systems contact me within the past couple of weeks to alert me to a challenging negotiation that is being done for 1/1/27, but just giving the heads up that they're struggling now and that this may take a long time, and it may not be the outcome that we all want, is that this health system stays in network with this health plan. So that is the first time that's ever happened with this much lead time and notice about a tough negotiation. Wendy, I want to probe a little bit with you, knowing that you've had other experiences recently with other companies. This issue of price. Is there anything employers can do about the price of healthcare? I know some of the things that we've talked about can help lower it, but the price of healthcare, do you have a perspective on what employers can do about that?
Well, I think Patty pointed out centers of excellence, and I'm a big believer in that. I know that she is as well. When you look at the variability of what a given procedure costs in a market, that's where I think this price component comes to life. So you can look at a total knee replacement in St. Louis, and it will vary from, let's say, 25,000 to probably 75,000, somewhere in that range. A centers of excellence is actually bringing that price to a bundled price. So it's predictable, it's transparent. And not only that, but they've also vetted those surgeons and the facilities to a different level. So that's where I feel like, there's a continuation of that dialogue because the carriers honestly don't have that same capability, right? They can't necessarily bundle as effectively, and they can't necessarily steer as effectively. And so the third parties have had good success, and I think we're seeing that in their numbers. The numbers are increasing pretty rapidly, with Lantern being somewhere around 12 million, Carum being somewhere around 8, and Transcarent being somewhere in the 5, 6. So, this as is an effective mechanism to get some price transparency and predictability. And to me, that's the way that we've got to continue to go in order to move the needle.
And I
Right.
I agree. I think, one of the things that employers have available today that they didn't have even a few years ago is the availability of that price transparency data that Wendy was referencing. So, in St. Louis today in the state of Missouri, you can get access to machine readable files that show the reimbursement rates that hospitals are reimbursed, inpatient, outpatient, as well as, from the carrier files too. And so you can look at for each of the individual hospitals and then by what they're being reimbursed by each of the carriers, by each of the health plans. And so with that, it really does illuminate as a self-funded employer how much you're paying for each of those, hip replacement, knee replacement, radiology, MRIs, CTs, how much you're paying by each of the carriers at each of the hospitals. And it really is it's pretty fascinating, quite frankly, to look at that really in any part of the country, to look at that data. And I think that can help inform your employer strategy about where to access care and where to steer that care. So it really is something I think that I'm seeing as an opportunity that a lot of self-funded employers don't realize they have access to today to really leverage that and drive their strategies going forward.
Yeah, it really is a new day, now that we have that data. And I say available with a little bit of a pause because it's not, those machine readable files, as we know, are not easy to translate. Are Mercer and Aon using that data to help employers with some of this?
Yeah, I can start first. So we have a new, we've leveraged and then spent a lot of time with our internal actuaries in diving into that data. And so we're serving up the price transparency. And then we're also going to be releasing next month the quality information. So we'll have a blend of value, as we call it, price and quality, because I think both need to be married together to look at the best value. And with that, then we'll be laying in the other types of care delivery strategies like centers of excellence to see in St. Louis what's available, as well as the alternative health plans that each of the carriers have. So that's one way to be able to access that information. So Wendy, what are your thoughts there?
Similar use of this from an actuarial perspective, and certainly, with employers moving to data warehousing more effectively in the use of that, and then tools such as Artemis and others that are available, then this is becoming more real. It used to be that we could not really pinpoint, right? But now we can really start to pinpoint where the problem areas are within a given employer, and that really helps us to focus because you can't boil the ocean all at once. We have to take strategic, focused approach to helping them solve their biggest issues.
Thinking about where we are in the year, right? We're through the first quarter, and most employers, large employers, which I know you mostly work with, have locked in or are finalizing their strategies for 1/1/27. What are you seeing in terms of where they're kind of placing their bets? Like what's rising to the top? Does anything feel different this year? And then are you seeing like real commitments to the strategies that we just discussed versus just talk? Like what are employers actually doing differently? And I remember, Patty, a conversation you and I had like last August, September, where you said basically employers' hair is on fire and we see them making changes for the upcoming year in 3 months that I've never seen before, like this wanting to make a change, wanting to do something different with this short of a time frame, before the 1/1 year. And so here we are planning again for 1/1. Where are employers and what are they thinking for next year?
So I think right now we're seeing employers have a greater willingness to make changes and make harder decisions than they have historically. Our latest survey showed that 62% of the respondents said that their managing healthcare trend is their number one benefits priority for 2026, which is up from 28% 2 years ago. So I think that signals a meaningful change and a clear signal that employers recognize we're in a new era here, and the 9.5% trend isn't going to go away. It's here to stay, and that real change is necessary and something that is going to continue. This is becoming the new normal, and I think employers need to react to it. So we're starting to see that shift.
Yeah, similarly, Mercer has a survey called Inside Employers' Minds, and that was just released. And we actually can do different industry cuts on that. So, but the statistics that Patty threw out are pretty similar for us too. There's certainly this increased willingness, I mean, like twofold, to turn over every rock, to have conversations that maybe the consultant has tried to bring up in the past, but they were like, no, we're not ready for that type of conversation right now, but now they are. And we always wonder, like, where is the tipping point? And it varies, right? There's some that have hit the tipping point because their increase last year was 15% or 20%. And they're like, we can't sustain this. We can't continue to push this to our employees in terms of the premium increases. And so we are going to look at things that we might not have looked at before. I have a few clients looking at reference-based pricing as a full replacement. So reference-based pricing, as we know, has been out there for a long time. It's been used in various and sundry ways, maybe for the out-of-network component or maybe as a slice. But there are some employers that have said, we've got to go all the way this year to make certain that we can deliver our employees affordable health care, because it's, in a high deductible plan that's become out of reach with a lot of employees, with the inflation rate that we've experienced over the last couple of years, with this kind of shrinking dollar that you have to use for your disposable income and to cover all of your cost. Then this is becoming an increasing problem, not just for the employer, but for the employee.
Yeah, so Wendy, just diving into that a little bit more. So are you referring to high deductible plans when you're talking about sort of affordability? I think all of us were part of promoting high deductible plans right back in the day, consumer-driven healthcare. When I worked at the New York Coalition, we had a lot of programs on why this is a good idea, and people are going to shop if you give them information. And now I've completely changed my opinion about high deductible plans. I think it's created an affordability issue. We even see where people avoid care. There was an article that came out in JAMA a few months ago that said people with diabetes had more complications if they had a high deductible plan because they did not use their plan and go to the doctor because of the expense. What are you seeing employers thinking about high deductible plans and affordability?
That's where they're leading into some alternative health plans, such as Assurus to Coop, one of Clear Choice, one of the alternative health plans that exist, by carrier. Each carrier has their own version of that. Tourist obviously is the United Healthcare and probably been around the longest. Everyone else has one as well. So I'm seeing that as a slice offering alongside a PPO or a high deductible health plan offering, so that you're giving some variability to the employee in terms of what it costs and the predictability of that cost.
Yeah, I agree. I think, I would say 2 years ago, we were wondering whether alternative health plans were a flash in the pan or a one-hit wonder. But now we're seeing that they're here to stay. And so that is our Aon's point of view, is that the alternative health plans are here to stay. We do think that high deductible health plans are still around, but we are seeing that shift of self-funded employers looking to address the affordability challenges. Really these alternative health plans provide bigger levers, whether it be bigger savings potential, higher opportunity for higher steerage to higher quality providers, as well as potentially a better member experience and better access as part of that. And so because of those bigger level potential to address the high trend, that's why we're seeing more of a pivot into these alternative models. So some of them, we think the concept is is definitely here to stay. As far as the name of the model, I think we're going to continue to see those shift. The carriers are all coming out with newer models, and I think those may change over time, but definitely that concept of an alternative to the traditional approach, I think, is here to stay.
I agree, Patty. And some of that is the employee mix. So we know that, within, let's say, a retail sector, you've got a lot of lower wage earners, and you have to understand that they can't afford a high deductible plan. It's just not capable. So they're either foregoing coverage altogether, or they're, just recognizing that they're never going to be able to use the plan to its fullest extent unless they have some sort of emergency type of healthcare need. We're also seeing a little bit of a move to at least looking at ICRAs. So, in the ICRA, you can obviously rate that a little bit differently, and you can basically tier the type of coverage, and it's a level funded defined coverage type of scenario for the employer to be able to define what they're going to contribute by level. So that has a little bit of attraction to some employers that, again, like we have to look at alternatives. We have to keep focused on, okay, if it's not this year, maybe it's in 28. So continuing down this, because as we all know, particularly with the large and the jumbo, this is like an 18 to 24 month cycle that we're looking at these things. And so we've got to be in front of it constantly. And so that's what I would encourage your audience and your employers to keep doing. We've got to keep kicking the tires. We've got to keep understanding the dynamics and the trends, and also what can and will work, and not say no. We've got to really open up the conversation.
I think the other thing we're seeing too is the rise of primary care again. I mean, we've all been in healthcare for a long time, and I think we're sort of getting back to the future on doubling down on primary care. Our latest survey showed that too, that employee, and it's coming in different flavors too, whether it be in the alternative health plan approach, the virtual first health plan, where about 80% of the care is done virtually, other 20% done in person, but there's steerage to high quality providers as part of that steerage. Those models, as part of the alternate health plan approach, are copays versus a deductible. There's more of a simplicity. There's better access with virtual care as part of those models. So those are the type of models we're seeing. Also, models that are PCP directed, like a Centivo type approach. I know Centivo's now in St. Louis. And that primary care we're just seeing emerge yet again, and advanced primary care models too, although that's not a true health plan election at time of open enrollment. Those type of models, and that's in St. Louis too, with some of the vendors like a Marathon and Premise that are leveraging on-site neuropsych clinics, again with like $0 copays. To address the affordability, predictability, and simplicity from an employee perspective.
Yeah, I agree, Patty. And on that advanced primary care note, before it felt like it was too disjointed, like there were not advanced primary care physicians all over the country in one type of network. And we're starting to see, like through Line Marketplace and others, that is a capability that is there. So that's exciting too. So you can actually make an advanced primary care model work across the country.
And I was able to see how this works up close when I worked at Centivo, and where, it was built on a primary care model, no deductibles, free primary care. And I was a Centivo member, and I saw how it worked from a member perspective. It was the best healthcare I ever had. And now at BHC, we've had United Healthcare for our own employees over the past couple of years. And when I got my renewal this year, for my 10 employees, I had Surest as an option, and I am now offering Surest to BHC employees. Again, I'm trying to walk the talk. I think deductibles are not good, and now the BHC employees have a copay plan, and I was really happy that I could offer that, to such a small employer. I'd like to focus on direct contracting. So Wendy, you talked about reference-based pricing, and I'm glad you brought that up, because that has always been something employers have really, tried to stay away from because of the friction with employees and consumers. We've solved a lot of those problems. But let's talk a little bit about direct contracting. I think having employers directly contract with health systems is a great model to improve the cost of care, to really push quality and ultimately value. So what are you seeing in terms of employers doing direct contracting, wanting to do direct contracting, and what are some of the challenges?
Yeah, it's really twofold. So on the health system side, not every health system is interested in doing direct contracting. Maybe they don't have the capabilities that they need, or, let's say, access to a TPA, access to, the analytics that they need. So it has to start from a market perspective and looking at the market and seeing, is there a direct contracting option? So, we see that in Dallas, for example. Baylor Scott and White's kind of a classic example of having their own health plan and a mechanism like their Quality Alliance that can achieve that. And they're very interested in doing it. The second thing I would say is there's been a stop start in that we've seen. They were doing it for a while. COVID hits, they had to stop and all hands on deck to focus on, what needed to be taken care of then. And then they've restarted that. There's not some magic network across the country that puts all that together. And so that's where, national employers have struggled a bit, but, they are leaning in to, let's say, having something in Dallas and maybe having something in St. Louis and maybe having something in New York as the three options that they can cover off in their employee population. Instead of doing nothing, they're saying, okay, we can lean in on these kind of high emphasis markets where we have a strong amount of employees and we can get something done there. So that's one aspect of it. And then, from an employer perspective, it's just that willingness to have some variability. It's not going to look the same in every market, but you have to realize that when you do lean into that and you have this, like maybe you have a high deductible option and you have a direct contracting health system option in a given market, that can make some, significant difference in your cost and your employee experience. And so then, that percentage of people that choose that option will likely grow year over year if it's going well.
I agree. I think we've seen now a rise of direct contracting. I work with clients across the country, and it's really because of the disputes from the contract negotiations that we talked about earlier. And so employers are looking for different options and markets. And I think we're starting to see a shift too, that some employers are willing to trade the broad national networks for a local custom network. And so with that, they're leveraging that the price transparency data to help inform maybe who is the best partner to select. And as Wendy said, though, that there has to be the appetite for both parties to be able to come to the table and have that conversation and to do a partnership. I'll say that self-funded employers are starting to have higher expectations, though, as part of that, and it's for the concierge level experience for the employee. I think that sometimes health systems underestimate the need and expectations around that experience and having a simpler healthcare journey, because we all know how complex that can really be from a consumer standpoint. Also, employers expect higher care coordination amongst the providers, that they work together instead of working in silos, and integrate from the provider perspective, and ultimately improve quality and lower cost. So I do think that direct contracting, there's a lot of opportunity, even in St. Louis and across Missouri. And I'm actually starting to see some employers think about direct contracting in a more non-traditional approach. I think traditional, we think of the employer approaches the provider, or the provider approaches the employer. Direct contracting, or direct to employer contracting, as a provider calls it, same concept. But there's also some self-funded employers are approaching me now, thinking of it from terms of a Centivo, for example. That why don't I just work with a Centivo? It's an easier lift from the employer perspective. Centivo does the contracting themselves and offers this custom network from their perspective. So I am starting to see this non-traditional definition of direct contracting come into play as well. So not only a Centivo, but like a Garner and Bold that steers. And so I think that's a newer notion.
And you touched on St. Louis, Patty. What are we seeing in St. Louis and Missouri compared to some of the rest of the country when it comes to direct contracting? In St. Louis, we have to your point, a couple of our health systems are ready. Like, they're ready to work directly with employers. Are employers ready?
Yeah, I would say that as I look at other markets across the country, I'm seeing St. Louis to be slower to adapt and to embrace, I would say, some of the innovation that is here. St. Louis does have some really good options on the employer side, but I'm just not seeing the self-funded employers embrace that opportunity as I am in some other markets.
Yeah, I would just encourage the employers in the market to not be afraid to have the conversation. There's no harm in having a conversation and really understanding at a deep level, because these health systems, I always have been perplexed by the fact that employers don't leverage in and know the health system and the capabilities as well as they should. And there's a lot of rich information there. If nothing, if you don't do anything, at least learning what the capabilities are and how robust the health system is a really, really important thing to know, particularly if you have half your employees in St. Louis, or, a decent population in a given market. Lean in on that. Use your consultant to help drive that conversation, because it's really important.
Can think about direct contracting. There's several different flavors of it too. I mean, you can do more of a toes in the water approach. Maybe it's just more of a well-being wellness program that you start with. I know flu shots at the very beginning, but then do well-being type strategies and going into centers of excellence that we talked about. And then you can do more advanced primary care focus, and then ultimately the bigger strategy of either having a tiered network as the health system is your tier one, and the carrier is tier two, or you can have the health system be your full offering for the year. So there's a few different options that are available. So I agree with Wendy. Just start. The key thing is just to start. I think one of the biggest challenges some employer, or the biggest competition a lot of our self-funded employers have, is not a different point solution or a carrier. It's the status quo. I think the status quo sometimes is the biggest barrier, and I just encourage everyone listening to just make a change, embrace a change, and even start small, and maybe make a glide path, a multi-year strategy. But work with your consultant to put together a plan, because I do think there are a lot of benefits to help mitigate trend that are out there in the marketplace today, that can be leveraged.
Agreed. And I think a strategic exercise is just to get in a room and challenge yourself over a 2 or 3 hour period to have more of an open-minded conversation. I'm hearing employers willing to do that. I'm always encouraging it as a strategic advisor. Let's have the conversation. Let's turn over every single rock in a dialogue. And then let's funnel that down to a set of focused initiatives that might be, to Patty's point, a glide path over 1 year, 2 year, 3 year, 5 years. And then we feel like we've got more. It's going to continue to change. We're going to have to continue to modify that plan. However, we have to understand what are all the capabilities out there at your disposal from both a carrier perspective, a third party perspective, a pharmacy perspective. That world's changing dramatically as well. So all these conversations, we have to take the time, and we have to put a stake in the ground and have that moment where we're discussing them all.
I love this advice. It's like crawl, walk, run, and employers should not be afraid to put their toe in the water. Well, I could talk to both of you for hours. We could keep going on this conversation, but we're coming to the end of our time. But I wanted to do a quick hit on two topics: point solutions and GLP-1s in pharmacy. So where are you seeing employers in terms of point solutions? Did they overbuy on point solutions over the last few years? If so, what are they doing now to course correct? And where do you both stand on point solutions?
Wow, that's a big question. I'll try to take a stab at it. So, what I'm seeing and what I like the most of what I'm seeing is that we're getting to a point where there's some stackability to point solutions. So there's some aggregation. So we're starting to see, I'll just use like a Hinge, for example, where they, been in virtual PT. Now they're in, migraine care, they're in women's health. They're going to continue to stack so that they can offer more and more things under one digital front door. And we're seeing things like a Solera Health and others that are offering, one digital front door. I think that's a great thing. I think the carrier side also, with their health hubs and their ability to align with point solutions and make it simple for employers to choose that option with a one-page amendment, let's say, also helpful, because then we're getting at the crux of the matter. You don't have to go through an RFP. You don't have to spend all this time. You really understand the ROI analysis pretty quickly, and you can jump in and go. And those are the things that will, to our whole point here, let's look at cost and quality. Those are the things that help to narrow that down and make it accessible and understandable and quicker, and which would make more impact. So I'm still a fan of the point solutions. We're in this world, though, where there are so many. It's almost impossible for us to keep up with them, not to mention an employer to keep up with them and to understand all the dynamics. So it takes an incredible amount of time. You've really got to lean in to your consultants and help them help you to understand this, because it is so big and so complex.
Yeah, I agree. I think in general, a lot of our employers are having point solution fatigue and definitely the PEPM fatigue. And I think now my advice would be to take an inventory of all the different point solutions that you have, and also look at the capability. So as Wendy said, the models, the business models have really expanded for a lot of these different vendors. Some of them, the space they're in, they started and that's their core, but then they've expanded. Maybe it's adding virtual care to it. So it's with the evolving models, I think it's really important to look at an inventory of what vendors you have in place today, as well as what capabilities you have, because you may be surprised at the duplication that you have across the board. So it's really important step to do that. And then secondly, totally agree with Wendy, leverage the data that you have available. If you have data warehouse, to look at the ROI across the board. We're seeing real focus on putting harder PGs in place, just to make sure that you're getting that ROI.
Yeah, those
Great
performance
advice.
guarantees are really critical, because the service level agreement. So it's kind of those can be the same, those can be different, but making sure that you're getting the depth of consulting that you need to look at those and to push. We're all guilty of maybe not going that last step, and we've got to continue to get to that last step of push. And the point solutions have to realize that that's going to be the continuation of their life, is more expectation from the employer and from their consultant.
Yeah, they're going to have to evolve and step up. So Wendy, GLP-1s, what are employers thinking about GLP-1s? Are they still covering them? And what's going to be happening for 1/1/27?
Laurel, it's all over the map. Everybody will be talking about GLP-1s in terms of the cost structure and how much they spent over the last year and what is their go forward for 27. What we're seeing mostly, I would say, is not coverage in the weight loss, or they've had to move to that because of the cost that they experienced, let's say in 25 and year to date 26. So they're making a decision to move away from it from a weight loss perspective, obviously still covering it for diabetic coverage. But it's also the reality of it's almost like a race to the bottom now on the price. And so that is a good thing in my mind, in terms of it's going to become more and more affordable. So then the employer can relook at it. And certainly we know that there's a lot of alternative pharmacy selection out there that has that as a core mechanism built into the reality, but that, moves away from a rebate perspective. So, this evaluation of, do we stay with a traditional PBM that's carrier driven, or do we go to an alternative? That's also where we have to spend time looking at what makes sense. And this is going to continue to evolve. So your decision for 27 might be different than your decision for 28 based on the equation, the price, the math, the capabilities of what the world looks like.
Because it is changing, isn't it? Yes.
It is.
Well, thank you both so much for joining me today. I think we had more agreement than anything else about, what employers need to do. Where are the opportunities to reduce healthcare costs, increase access, provide a higher quality benefit? And I love that the two of you are in leadership positions at Aon and Mercer, two of our, big partners in helping employers figure this all out. So thank you so much for being with me. And thanks for listening to Be Health Connected, empowering healthy workforces one conversation at a time.
Thank you for listening to the Be Health Connected podcast. For additional episodes, or to learn more about employer resources available through the Gateway Business Health Coalition, please visit www.gatewaybhc.org.